Welcome back to the T1 Dialogues. I'm Jack, a type 1 diabetic creator, and my co-host Pete, who's CEO of Not Just a Patch and is also a type 1 diabetic. We are interviewing heroes of the diabetic space, and today we get to have a chat with Beck Newton, the Not Just a Patch grant winner.
The Australian grant winner. Hi everyone, and great radio voice. I thought you were kidding there for a second, Jackson, but you weren't. So happy to be doing another podcast. Happy to be doing it with Beck Newton. Just a quick background for listeners. So we've been running a grant program for the last 12 months, where we've invited healthcare professionals, specifically, more specifically, diabetes educators and nurse specialists, to apply for the grant program. We've had $1,500 available in Australia, $1,500 in Europe, and $1,500 in the US. And it's really just about how we could give back to the community and support a group of individuals that we care a lot about because they care a lot about us. That's really what this is all about. And so this is the first interview. It's with Beck Newton, who's in Western Australia, who has developed a service specifically for people living with type 1 diabetes who are experiencing disordered eating and eating disorders. And I'll hand over to Beck now to introduce herself and give a little bit more background on herself, how she got to this point, and then we'll sort of dive in a bit more deeply. Hi, Beck. Thanks for joining.
Hello. Thanks for having me. And thank you so much for the grant. It was so exciting to get that email. It's very cool to sort of, win something.
Happy to help.
Yeah. But I think more importantly, it's going to give me some funding to do something that is, obviously really close to my heart. So in terms of my background, I have been a registered nurse for a very, very long time. Pump Up the Jam was playing in the nightclubs when I was, sort of newly graduated, for the first time round, not to reboot. And so I've been working in many, many different areas of nursing over my career. Found myself, ICU nurse, neurosurge nurse, and then I went to the country and became a mental health nurse, and then kind of went into management and leadership and ended up at the health department for a few years. And kind of, about maybe 8-10 years ago, I started thinking, I'd like to go back on the tools, but I don't know if I want to do that as a nurse. And I was getting much more, interested in my own nutrition, and really could start seeing how important nutrition was to chronic disease prevention and improvement and that kind of thing. So that led me to a dietetic degree, and I ended up doing my master's in dietetics. And along that journey, I kind of realized that, with my mental health background and now my dietetic skills, I probably had something to offer in the eating disorder space. So that's where I thought I was going to go. I thought, I definitely wanted to probably work with type 2 diabetes in terms of the chronic disease and how diet can really improve things in that way. But the eating disorder thing kept coming back as well. So I started doing lots of upskilling in that area, knowing full well that anyone that walks through my door will probably have some kind of disordered eating or eating disorder going on, because most humans do. So that kind of, started the eating disorder interest. And then I had become aware of the Type 1 Diabetes Family Centre as like a really unique service. And the dietitian, particularly there, Amy Rush, who's also a CDE, she, did a lot of work in the low carb space and that kind of thing, which is still a little bit of a no-no, not no-no, but, we don't have a huge amount of evidence, I guess, in terms of the literature to support that. But she was someone that's willing to help people who want to do that rather than them doing it themselves without any help, which, all the guidelines will say to us, if people want to change their diet, then doing that with help is always really important. And so I was really fascinated with what they were doing at the Family Centre. And then just as I graduated, a job was advertised for a diabetes educator and dietitian. So threw my hat in the ring, got offered the job, and I've been there 3.5 years now. And so that, I guess, brought me into the type 1 space, which I hadn't planned to come into, hadn't, sort of realised enough, what I know now about type 1, which I should have known way more about it back then, has brought me into this space. And again, really quickly realized that a lot of people I was talking to were having issues with eating and insulin use and all of these things that were coming up for, managing body shape, body image, all that kind of stuff. So realized that there was a missing part of the puzzle there. And I guess having worked in both diabetes and eating disorder spaces separately, both do each of those things really well, but bringing it together doesn't seem to exist. And I guess that's where I thought, well, that's maybe somewhere I can help out.
So did you have to sell the concept of a focus on disordered eating and eating disorders to your employer, the Type 1 Family Centre in Perth? Did you have to sort of sell to them the need for this specialization, or was it something that they were looking for? How did that part come about?
No, I think I think I raised it as something that is potentially an area, and I guess a unique skill set that I have, but a unique kind of service that we could offer too. We are, at the Family Centre, we are a very unique service in the fact that we only look after Type 1. Apparently, we're the only service in the world that is specifically for Type 1. And, and our service is very much geared around community, peer support, bringing lived experience into, I guess, our clinical expertise and bringing those things together. And so very much always interested in things that can help our people and help our community. And I was seeing it in my clinic patients. Amy was too. There's since been a lot more people come on board, and we all know that it's there. I guess I took it to.
Do we know the size, the focus that you're wanting to take? Were you aware there was a market there?
No.
Or maybe the better word is a cohort.
Yeah.
Or there was a need in the community, really. And did you have to prove that need existed before you were able to kind of move into the specialization?
Are we talking about a strong correlation between eating disorders and type 1 diabetes?
Yeah. So I guess to answer all of those questions, I guess I have a focus on those things. And so I will probably ask questions to peel information out of people that maybe other people don't ask because they don't have that experience or knowledge about the disordered eating side of things, at least. So I had to sort of work out for myself, is this something that I'm just kind of pulling out, or is it something that's way bigger? And so that led me to sort of doing some research on my own and, found that there are guidelines, like Queensland government put out guidelines for people with type 1 living with disordered eating as well. And, from that and, sort of digging a bit deeper, I found out, so there's 1 million people in Australia who have some kind of eating disorder. So that's a clinically diagnosed eating disorder. That doesn't account for anybody that has disordered eating. And so the difference is one's, diagnosed by a psychiatrist or a clinician, and the rest of it is, going on diets or calorie restricting or, exercising, all those sorts of things that, people do to try and manage how they look and feel. So we know there's 1 million people that have.
Is that 100%? Like you mentioned earlier, it's a human condition. Like, does everyone have disordered eating? Does Jackson? Like,
I don't know. Do you? Do you think about what you eat? Do you feel like, do you feel like you are eating good or bad things? Do you feel guilty for eating certain things?
Yeah.
You guys have type 1 as well, so you're going to have, oh my God, I'm going to have to calculate this as well, right?
We have a skewed vision.
Yeah.
We have a skewed vision of what food is.
Yeah. So that kind of answers your question, Jackson. Yes, people with type 1 have a higher risk of eating disorders, and we're not sure why, but we probably think, it's got a lot to do with the hyper focus on food. You have to, be at least very conscious about your carbs that you're eating. You're having to count them to work out your insulin. Certain foods will skyrocket your blood glucose. There's certain things that you have to be aware of just because of the the type 1. So the stats will tell us that people with type 1 are at a 40% higher risk of eating disorder, more so in females, adolescent and adult females, but there's about a 13 to 15% increased risk for males as well. So we know that there's definitely a correlation between the focus on food, but with the disordered eating in type 1, it's, we have the classic kind of eating disorders are present there too, but we have this unique thing that people with type 1 can do, and that is manipulating insulin to kind of help with weight control as well. And so I think when people are newly diagnosed, often, diagnosed with rapid weight loss, thirst, hunger, all of that sort of stuff, and then someone says, oh, you need insulin. And what happens? Do any of you guys remember what happened when you were first started on insulin?
Well, people put weight on, don't they? I didn't, but generally, I think that's the. Did that happen to you, Jackson? Did you put weight on when you started?
I diagnosed myself really early, so I didn't lose weight to put it back on.
Yeah.
And I was training for a marathon, so I was skinny anyway.
Okay, yeah.
I was right in the middle of training. But anyway, I think we're probably exceptions to the rule.
But
we can definitely relate, I think.
Yeah, as you guys know, a lot of people get diagnosed with DKA. They are, have lost a lot of weight. They're breaking down fat to create energy, and so they have this kind of period of rapid weight loss, and then the process of starting insulin, is recovering the weight they've lost, and can make you a bit edematous and make you a bit fluidy and a bit, feel a bit gross when that body's kind of going, oh, wow, I remember what this insulin thing is. And people don't like that feeling. And people might
they quickly learn the correlation, don't they? They quickly realize, hey, insulin puts weight on. And then they go, oh, okay, so no insulin declines weight. And so then immediately that's in your head, and it crosses my mind. Like I sometimes go, oh, I'm high. Well, the upside is that maybe I'm skinnier than I would be if I wasn't high.
Yeah. And that's what I mean about that, like that human kind of, we have this kind of, I guess, societal pressure, this kind of internal thing to look like people we see out there. And there's all this, kind of general stuff that, makes us, we're fat phobic. There's being overweight is stigmatized, all of those sorts of things. So, I guess when people go through that experience of, maybe a type 1 diagnosis, that weight shift, it can lead to sort of that thinking, but it can also lead to a lot of body dissatisfaction and that kind of thing. So we know that probably plays a role as well in kind of that ongoing development of something like that. And I guess people quickly work out that maybe they have a tool that they can use, but it's a really dangerous tool too. And, we know that insulin is essential for life, otherwise, without it, you're not going to do so well. And I meet people daily who are living on the edge of diabetic ketoacidosis or are in ketoacidosis to manage, their body shape. And it's heartbreaking. It's absolutely heartbreaking because, they will end up in hospital. And, we know that eating disorders are the highest mortality, so the highest death rate out of all mental health. So they're higher than suicide. But, we don't hear about it, right?
No, that's a stat that I think we need to hear more often, to be honest, because it is a bit buried, that one.
Yeah. And people with eating disorders, will do that too. But, a lot of it comes from the malnutrition and, for someone who is omitting insulin or manipulating their insulin relative to what they need, then that puts them at a much higher risk of DKA, which, as you guys are aware, is, super scary and deadly.
So what do you want to talk us through, like, specifically what eating disorders we're referring to? Like, I think we're probably, and I should be cautious with terminology because I don't know if things have moved on since I learnt the terms anorexia and bulimia, but like they're the two that are there others what's new, I suppose, in those spaces?
Yeah, so I guess so the diagnosable eating disorders are, like you say, anorexia nervosa, bulimia
Mm,
nervosa, binge eating disorder. We have one called avoidant restrictive food intake disorder. We have a group called other specified feeding and eating disorders, and we have things like rumination disorders and other sort of, unspecified feeding disorders as well. So they're the things that are, I guess, DCM or ICD kind of diagnosable conditions. Okay.
mm-hmm.
So they are things that any human being can be diagnosed with. And there's certain criteria to meet for all of those things. The world of diabetes and type 1, and this happens in type 2 too, actually, but also in type 1, the thing that we have heard about might be diabulimia, and that is not a medical term. It's a term that's been kind of coined by media and people living with type 1, and people living with type 1 like that name, so we're pretty happy to use it. So, but diabulimia is where that manipulation of insulin comes into it. So someone may be experiencing anorexia nervosa, for instance, which is generally categorized by a restriction in energy or food intake.
Mm-hmm.
And, coupled with insulin manipulation can make that pretty scary. Someone may have type 1, have severe hypos, starts a hypo treatment, sets them off on a binge cycle, and they can't stop eating. And so that would technically be, a binge eating disorder. Some people may purge after that, and so that would be more like a bulimia type disorder. So it's not that different, I guess, to people that do not have type 1 in regards to the types of eating disorders that people are prone to. But the manipulation of insulin is probably the big difference, and it's a unique kind of difference for people with type 1.
I mean, I feel like I'm familiar with the idea of having a hypo, going to the fridge and starting to eat something and then just kind of, getting out of control, right? And kind of having like 3 meals, in the space of half an hour.
Yeah.
But like, I think it's interesting where people sit on the spectrum, right? I wouldn't consider myself to have an eating disorder.
Yeah.
I don't know if that classifies me to have disordered eating, but
Yeah.
like, is there a regularity to that would then make
Yeah.
me someone that needs to seek out assistance?
Yeah. So I guess it depends on, it's probably not something I can answer, in terms of the answer for
Yeah,
everybody, because everybody's so different, right? But
yeah,
I think that, I guess, the key factors is in, how it makes you feel about yourself. It's how, the reasons, I guess, that you're doing something. And if it is to kind of, uh, you know, um, change your body shape, or
mm,
trying to meet a certain expectation, if you've got kind of little thoughts that come up and give you guilt and shame about certain things, then
mm,
that would
mm,
probably fit more into sort of the disordered eating kind of thinking.
yeah,
Whereas what you're describing, Pete, is, it's that primitive hunger, like your blood sugar is low, your brain's
yeah.
going to tell you
That's a
it's
good way
to
of describing
survive. It's a survival thing, right? And it's a really
it. Yeah.
normal thing. And that's what sucks about it, because your brain has taken over and you can't stop. And, and then you sort of all of a sudden high, and you're like, oh crap, now I need to do a correction. You're on that roller coaster ride.
I mean, there's a little part of me that does go, well, this is your chance, gorge yourself. Like I sort of go, the floodgates are open, just enjoy it. You know what
Yeah,
I mean?
yeah,
Like,
yeah, yeah. Yeah,
it's very,
and
I don't have that many hypos now, but like, there's definitely a consciousness to me going, I'm gonna let myself just, go go a bit crazy with food
yeah,
for a
yeah,
brief moment, and I'm gonna excuse myself because I've got a hypo.
Yeah,
I don't know
absolutely.
about you, Jackson. Do you have a similar what's your dialogue when it comes to have you ever gorged yourself where you've had a hypo excessively?
Yes. And I think that's where I think this is such an interesting space, because diabetes is based around how we eat to survive every day, constantly thinking about it. So it's so easy to sort of like it to develop into a bit of a mental game. I mean, as type 1 diabetics, we're restrictive with our eating anyway. We also binge, like you just said, to survive. We are constantly thinking about it, and I'm always testing out fad low carb diets to help me manage my diabetes. But I guess that's where it's really interesting to hear all this, because we may always be on that spectrum, but I guess it's how far the mental side we
Yeah,
fall
yeah,
into,
and
and
it's
how
obviously
much we start becoming reliant.
that's it, and it's that kind of change in your, I guess, the attitude inside your own sort of mind in terms of what's driving you to do those things. You know, if it's managing diabetes, blood glucose, and choosing certain foods because you know it makes you feel better and you know it keeps your blood sugar stable and all that kind of thing, well then, that's a great way to be, right? But it's when it becomes that you feel that you can't be in control of it over a certain period
Mm,
of time. It's
yeah.
when you are manipulating things to have an outcome of weight loss or different things when maybe you don't need to, and there's so many things. It's really really difficult to kind of just sort of answer in one big sort of sweep of the brush, but I think it's when it becomes distressing, it becomes overwhelming, it becomes that you are not medically well. So, you
Mm,
may start getting sick. You may end up in DKA a lot of the time. You may be having a lot of hypos, just things that are not good for you, right? That's when it becomes a problem, right? And what you guys are describing is kind of day to day living with the lovely life of type 1. But
mm,
and what is it, the 160 extra decisions that you guys have to make compared to me every day to just get through the day, which someone whose pancreas is spitting out insulin can kind of get away with, and we don't think about it. You've also got that CGM thing looking at you constantly as well, and beeping at you and telling you whether you're doing well or not so well. And then you've got awesome health professionals like us, kind of going, giving you yep, your HbA1c is good job. And, all of that stuff. There's so much
mm.
pressure for someone with type 1, both from yourself and from the outside
Yeah.
world to
Well, we
manage.
have a we have a relationship with our bodies, right? And an insight into what's happening metabolically
Yep.
that's kind of above the normal person. We get to see and
Yep.
monitor, what's happening with glucose, and kind of we're more closely kind of in tune with food in our bodies.
Yep.
And I guess that's where it starts in that, you mentioned the 40% or 13% for men, adolescent, I think it was 40% in female adolescent and
And
13 in male adolescent type
yep.
1.
Yep. Yep.
Um, and that's maybe where it starts, is like, if you have got that closer relationship,
Mm.
it's maybe easier for that to tip over to become an unbalanced relationship. Like, I guess that's the thing.
Yeah.
Like, I think mine's balanced, but like
Mm.
I could see that it would be easy if there were other changes in my life, psychosocial type things happening, that I could potentially, just go off the tracks because of
Yes.
this focus in food, and I could get too skinny because
Mm.
I'm too conscious of, like, fasting, for example, or I could imagine that all of this stuff could be somewhat intermittent. Like, you could potentially go into like disordered eating for a few months and then you'd come out of it.
Yep.
So I guess it's just always there if you're not cognizant of it and you're not seeking help, that this stuff can be happening without you even knowing.
Yeah, so I totally agree. I think people with type 1 have a superpower in the fact that you are really aware of your body. Yeah, like you were saying, Pete, you're able to kind of really understand how what you eat impacts blood glucose, your mood, how stress can impact your blood glucose, all the other factors, what is it, 42 factors that affect your blood glucose, which, also affects my blood glucose too, but I'm not aware of it unless I'm wearing a CGM, which most people aren't. And then you've got this kind of amplified kind of, you can see this big peak and this big trough, and then often go, oh my God, what did I do? And then you react to that. So I think you're absolutely right. I think if there's so many other factors that kind of predispose someone to disordered eating and eating disorders, that on top, with type 1 kind of topped onto that, it kind of just increases that risk a bit more because of that hyper awareness, that experience with insulin, changing weight. I think I know that this of some of the younger ladies that I work with, just like that kind of having to inject in public and, wearing devices and things like that, that affects your sort of body image and how you feel about yourself too. I know young guys that are, won't inject at school and, and on work sites and things like that because they don't want to sort of, let other people know. Yeah. So, it's all of those other things that, I guess play in our mind about how we feel about ourselves, our own self-esteem, how we feel about our bodies, all of that sort of stuff. So, I've certainly met lots of people who have probably had eating disorder stuff going on before type 1. And then type 1 has kind of accentuated that. And vice versa. Maybe, the type 1 came about, whether or not it caused an eating disorder, we don't know. We don't know whether that person may have got an eating disorder anyway, but type 1 kind of throws up the opportunity, I guess, to do things in a little bit of a different way to what a regular eating disorder might do.
This is the perfect segue to find out you're using this grant to set up a service. Can you tell us about this service? Are you going to help I guess, define what diabulimia is and how to diagnose it? What's this? So how are you bringing these two big elements together?
Like we see kids and adults turn up at, their diabetes appointment, and often the first thing that happens to them, height, weight, HbA1c. And often, other than HbA1c, nothing else is discussed. So it's like, well, why are you weighing this child or this person if you're not going to talk to me about it? Like, what's the point of that? And so without that understanding about why someone's being weighed, you're assuming it's kind of like almost like a report card, and they're like judging me on it. So I want to empower, I guess, parents to ask their clinicians, why are you weighing my child? Why does this need to happen? And kind of explaining, that, height and weight for a child is about growth and development. It's not a fat check. It's about checking out whether that child is growing, developing in the way that, is expected. It may also be for calculating insulin doses. So it is really important at times, but it shouldn't be done every single time unless there's a reason to do that. And so, empowering parents to kind of go, well, why do, explain this to my child, and ask the clinician, can you just explain why this happened, and that kind of thing, just kind of give them the tools to sort of be a bit more empowered with that, I think. And I guess just to kind of, just some of those early warning signs, just to sort of, check out that education around that, weight gain or weight, it's actually weight repletion. So it's actually getting that weight back to where that person was pre-diagnosis. It's not actually weight gain at all. And that's a really normal process, and it will level out over time. But, that initiation of insulin for the first time will probably make you a bit puffy, will make you, feel like you're a bit kind of fluidier than usual, and it's not very pleasant. But it's a normal process, and it will peter out. So it is kind of giving them those tools so that they don't necessarily think, oh, insulin's bad. Insulin makes this happen. And trying to give that information early, I think, is really, really important.
Yeah, prevention via education.
Yeah, so that's one of the things. So that's what I kind of want to do with parents. The other side of things is, I'd really like, so I guess promote the fact that I am offering this service. So again, I've got to be careful because there's only just one of me too. So it is kind of trying to let people know that there is a service that is available, and I guess.
Mm,
And I think I may have put this in my application with you guys, some sort of measurement, like being able to kind of go, well, is what I'm doing helpful? Is it not? Trying to sort of work out whether or not, the sort of work I'm doing with people is making a difference or not. And then I guess that can be replicated. I can teach other health professionals, the sorts of things that I do, and hopefully expand the workforce as well. I have had the opportunity to talk to some dietitians who work in, pure eating disorder inpatient services. And about, I guess, some of the difficulties that, I know some of my patients have experienced when they've gone into an eating disorder hospital, and spent 12 weeks in a place to try and improve their eating disorder. And for someone who
mm,
may eat a little bit lower carb or something like that, suddenly getting bombarded with huge amounts of carb skyrockets their blood sugar, makes them feel
mm,
terrible. Kind of just making them aware of, that uncomfortableness. Like, it's scary enough having to be refed if you've not been eating for a long time, let alone when you're now watching your blood sugar skyrocket as well, and you've got that additional stress. So, so trying to sort of, I guess, teach my colleagues a bit as well. So that would be really
mm,
important. But yeah, I think it's around that kind of awareness raising, and like I was saying earlier, to me, it feels like it's a condition that's hidden in plain sight. It's not something, unless someone starts scratching
mm,
at the surface, it's a very easily hidden condition. Like I know a lot of the people I see, that their blood sugars are really, really high, and their team of people may be just saying, well, you're not looking after your diabetes well enough, not actually
yeah.
realizing that it's an intentional thing. Yeah, yeah.
Do
So
we
yeah,
have any sense of how many of this, I don't like this word either really, but cohort of individuals that might be classified as disordered or eating
mm,
disorder, how many are actually seeking treatment, where they're seeking treatment, how many are just managing on their own, and like, you know, what's the current awareness like in the community? Do we have any sense of those numbers at the moment?
not that I'm aware of. Like, the only numbers I know of is that we think it's about, like the risk factors more than anything, that, it's that extra sort of 40%
Mm,
compared to people without type 1. Um, like eating disorders is growing across all populations. So it's a big problem already. And I guess, the fact that someone with type 1 is just at that greater risk. And I think for
mm,
me, that greater risk of developing the type 1, but also the greater risk of, severe complications and death is greater in
mm,
someone with type 1, because of that sort of seesaw between, well, probably both, but what, when someone turns up to see me, it's kind of like, well, what's the biggest risk factor here? Is it the malnutrition, or is it the DKA? And we
yeah.
have to sort of work with what's going to be most dangerous right now, and trying to sort of work through that first, knowing that we have to work with both. And so I don't think we have those stats. My feeling is that someone that turns up to an emergency department will be turning up with malnutrition or DKA, and they'll be treated for that singular thing and then sent home again,
Hmm.
without kind of bringing it
Yeah.
together. Oh, this is actually working.
Without like a psychological assessment and consideration of like what needs to be
Mm,
managed on that side.
yeah, yeah,
Yeah.
yeah. And I
So
think,
that's almost like as much about education and awareness in the medical community, isn't it,
oh
as it
yeah,
is in
yeah, yeah,
the patient community, like
yeah.
for healthcare professionals to be cognizant and picking or
Yeah.
looking for things
Yeah.
as much as patients to be aware and seeking help.
Yeah, I totally agree, and I think that's something that I'd like to sort of work on too, and
Mm.
I do a little bit of sort of sessional academic work through our diabetes education course at one of the unis here, and it'd be so good to be able to kind of get that kind of education into the health professions at an early stage. But like that's a diabetes educator cohort. I think people in general kind of medicine, nursing, emergency departments probably don't know enough about type 1, let alone eating disorders, and then bringing that together. It's a big ask because and
Yeah,
GPs too, they've got to
it's a big ask.
yeah, GPs got to get their head
Yeah,
around.
it's a big ask for.
Yeah. Yeah, so I think
Yeah.
as diabetes educators, like we need to be better at asking those tricky questions and, kind of, digging deep when we
Mm.
see certain things that, are probably red flags to me. Yeah, but you need to have the education and skills about, and feeling confident to ask people about those things. I think, where I work, we have a type 1 specific psychologist. So Nat only works with people with type 1. So that in itself is so good too, because people can see myself, also see Nat. They don't have to explain type 1. So that's done, so they can just kind of get to the nitty gritty about all the other stuff that's going on for them as well, which can be really, really helpful.
Beck,
Beck,
sorry,
wow.
Jackson, you go.
A big congratulations for winning the grant. What you're doing is really changing the space of diabetes. I'm just for everyone that's watching or listening to this, where can people find more information
About the eating disorder stuff or what?
about what you're doing,
Yeah,
eating disorders,
yeah, yeah.
diabetes?
Yeah, I guess, I would funnel everybody to the Type 1 Diabetes Family Centre here in Stirling in Perth. It's an awesome place. We have a Facebook community, which we have different groups. We have one for people with type 1 who are adults, parents of people with type 1. We have a Southwest community. We have mums and bubs groups and things like that. So it's a really, really awesome place to sort of have a vent, borrow equipment, like all sorts of things go on there. For people that live in Perth, we have regular, coffee catch-ups, dinners, all sorts of things. We run lots of education out of the family centre too. We have online courses. We run face-to-face courses, lots of stuff to try and, our job is to, I guess, empower people living with type 1 to self-manage. And, they shouldn't need a diabetes educator. So if we're doing our job well, we'll be doing ourselves out of a job. So my information's on there, but I have my own website too. So while I work at the family centre, I also have sort of my own private practice, which I work out of. So I can, do you want to put those details up somewhere? I can.
Yeah, what's the URL or the name of the business, Beck?
So I am eatlivewell.com.au, and I can't remember what the type 1 family centre is, but I can send it to you later. Maybe you can put it in the notes.
That's
or something.
okay. People can Google Type 1 Family Centre.
Yeah.
We can put it in the notes as well.
Phone number 08 9446 6446. And most of the time when you ring that place, you're going to talk to someone that has type 1. So we have a big team of staff who live with type 1, and I often hear them talking to people about a shitty day they're having or something that's going on for them, and can actually kind of help them out, and then refer that person on to one of us as well, which can be really, really good.
Thanks for sharing your story, Beck.
No worries.
Fantastic.
Thank you for the grant.
No, like this is it's really pleasing for me because you never really know, like when we set the program up. It's the first time we did it. We didn't really know how it was going to turn out, and like hearing the story, I mean, it's again, I want to be cautious of my words. I don't I find it fascinating, right? Because I've got type 1, and have a general interest in mental health, and like want to support people who need help. And so I think that this type of specialization, this type of education and awareness stuff is like exactly why we started this. And so like really happy that we got to talk to you, happy that we're supporting in a very small way, and keep up the good work, Beck.
Thank you.
Yeah,
Yeah.
I love what you're doing. As I said in the pre-interview, that I do have friends with eating disorders and diabetes. It is prevalent in the community, and it's great to hear someone is doing something, or at least investigating and educating.
Yeah, and I
So
think,
thanks, Beck.
Jackson, sometimes I kind of I get this feeling that I get this sigh of relief that, oh, thank God I've been found out. Like when I'm talking to somebody, because I think it's something that, eating disorders can be really stigmatizing, kind of you don't want to tell people about them. It's kind of very secretive. Type 1 can also be that too. And so when those things are together, it's almost like, oh, this person's asked me a question, I'm answering it, and oh my God, now they know. But thank God now they know because they can help me. Yeah. So
And so
no,
normalizing it, right? Like
yeah,
normalizing it and, you know, sharing our stories about gorging in front of the fridge at 1 a.m. in the morning and like and the guilt that's associated with it. Like
yeah,
that's a starting point, right?
yeah, that's
Yeah,
right.
good confession, Pete. Just this is really our way to confess all the times we've binge ate at 1 a.m.
I'll just tell you about how many Easter eggs I've just eaten.
I had two after lunch actually. I actually injected while I was on this call because like I
Yeah.
realized I needed more.
Yeah.
And I suppose it is pretty timely with Easter around the corner, isn't it?
But we're humans. That's what humans do, right? And it's okay.
If you enjoyed this episode with Beck Newton as much as we enjoyed making it, please like, subscribe, and leave a review. If you're watching this on YouTube, this is also going to be made into a podcast. I'm Jack, type 1 diabetic, content creator. Already getting excited for next week's episode, where we have a chat to the European grant winner, Nadia Roberts. Hope to see you there.